I don't know, David, if you heard. I can tell you something, you know, in a passionate way. If there's a treatment anywhere in the world that works, you bet we're going to go in this country and take it and bring it here. Period. No further. You bet. So that's something that you bet. And even if we don't understand how it works, you bet it's going to come here. Whether it's the right way to do it or the wrong way, it's going to come here. I can tell you things about, because I've seen patients going to Germany. There's a vaccine. We talked about the adjuvant study. You remember when Choueiri? There's a trial that is published in a very respectful journal called The Lancet. 10 years ago, David, 15 years ago, that uses a vaccine from patient, and it shows, the trial, that it decreases the risk of recurrence by around 30–40%. When they applied for approval in the United States, and I'm not sure even it's approved in Germany, the trial is published, and when we train in the field of kidney cancer, when we go to Journal Club, you know what Journal Club is? We take an article and we just kill it. We say, this is wrong, this is what they did. It has so many flaws in it that even the FDA refused to consider it. So an example, there was 400 or 500 patients in this, and 200 on one arm ended up not getting the vaccine, but counted as they get the vaccine. And 100 in the other arm ended up getting the vaccine, but disappearing after 2 months from follow-up. And on and on and on and on. And people that, because there is way how to report it. So if someone drops off treatment, you cannot consider that a treatment success. You have to, by default, be conservative and consider it failure. So when this particular company, this approach, the US here said that this trial, despite published this is not true science. So I think, you know, and I've seen people going to Germany and getting it. Another one I heard about, in fact, is the trial in Russia with a vaccine. This was another big paper of another vaccine that completely, when the results were presented, the trial is completely negative. And in the US, it wasn't filed. But in patients that have very early stage disease, there was some people that it may help them. It wasn't statistically significant. And for whatever reason, the drug was approved in Russia among all. And when we looked and said, how could that be approved? Especially that the patient really you want to help the most, the one that have early disease, are the one with stage 3 and stage 2 high, because those are the ones that have the high risk. In stage 1, the chances of it coming back is 10% or less. So it doesn't make, but it made it. How it did, this is why we have somewhat a high standard here, and we take a look at the studies. But yeah, I've seen things. Heating particularly, I haven't heard. What I've heard is in stroke, in patients with stroke, and it's been adopted now in the United States, cooling the body and cooling back and forth the circulation decreases the amount of nerve damage and brain damage. And because a lot of people can't make it to the hospital within the 6 hours or 8 hours, and you know, once the brain, there is no cells that regenerate. And that's the only place I think I heard with cooling. David, can you add on that?
I have nothing informed to say about heating or cooling.
He's not in the AC business.
That's right, except for this one. Okay, other questions before we wrap up? Other questions? Okay, good. Excellent. Thank you, Tony. Thanks for all the good questions. I just have a couple more slides. People asked a couple of things today about the program, about that we work in as a group, and I wanted to give a few slides about that research program. Because it's only through research, as we talked about, that we're going to be able to address some of these questions. So we've obviously asked, you guys have asked a lot of good questions. Here are several more that we've sort of tried to address. The point of this slide is we've got a lot of work to do. We've got a lot of questions to answer. We can only answer those questions together, meaning not just the doctors coming up with ideas, but getting feedback from people like you, and most importantly, getting folks like you involved in raising awareness about the importance of research. The future directions, we hope to go getting to the question about focusing people's treatment based on their tumor. We obviously need to do a lot better at individualizing treatment, knowing how long to give treatment, when to switch, whether we can give treatment to people with other issues, medical issues. That's becoming more common now that these drugs are being more widely used. Those are all important questions. And this is the group of folks that we work together with to try to address these questions. This is the group of hospitals in Boston that make up the Dana-Farber Harvard Cancer Center. All of these hospitals are Harvard affiliated and work together on a research level to deal with a variety of different cancers. We do have, as you know, a kidney cancer program that was established in 2002. It's one of 9 disease-based programs within the Harvard Cancer Center. And it's one of the few multifaceted programs in the country of its type, that's for sure. Here are some of the main activities and things we're working on. You've heard a lot about this today. I won't go over it because we're almost done. The point is there's a lot of interesting work going on. And while it's funded in some ways better than many places in the country, we obviously could use a lot more support on the funding side, particularly funding young investigators who might be interested in doing kidney cancer research. They're much more likely to do it if we can support their careers. This is a picture of several of those people who are involved in this research. This is just a portion of the folks who are involved. It's a large group of people across many different institutions in Boston. There are patients who are trying to help us with this. This is an example of one of Dr. Atkins' patients, Bob Rebello, who is a survivor of kidney cancer. What he does to help us raise money is he does marathons around the world and raises money for us in that regard each year, running several marathons. Obviously, this is not for everyone, but it's just an example of how one person who's very motivated can make a huge difference, and his support goes to support young investigators doing cancer research in kidney cancer. So sort of in summary, my last slide, I think we've gotten a sense that we're making progress here. Hopefully we've conveyed a sense of hope and a sense that community is important and getting to know one another and advocating for each other is important. Hopefully we'll continue to make progress through better therapies that are more targeted, through patient advocacy, which we really need to beef up in the kidney cancer world. We need to be much more like the folks in prostate cancer and breast cancer. We get a lot more attention from the funding organizations. And we need to do a better job of fundraising as well. And if we do all of these things, I think we'll make progress. And hopefully, going forward, maybe in this decade, we'll get to a situation where we can create a treatment that's based on a patient's particular profile, genetic profile, and that the treatment will work, remission will be accomplished, and then no alternative treatments will be indicated, no second-line treatments indicated. This is sort of our future, a much more simplified algorithm than what we have now in 2011, and with your help, we hope to accomplish this. Thank you all for attending. We hope to see you next year.